All right, types of manual therapy. You guys just come back from clinical. Let's do it. List them. Types of manual therapy. Go.
Massage.
Soft tissue what?
Mobilization.
Soft tissue mobilization. Okay. Next. Massage.
Active range of motion.
Active range. Wait.
Passive range of motion. Passive range of motion.
How about we do this? How about we do active assistive range of motion?
That's really what I was going for.
Okay.
I'm gonna walk.
Anything else?
Passive.
Yes, Jeff, it is on there.
Okay. Certainly passive range of motion would be on here. Anything else?
Stretching.
Stretching. Manual stretching? Sure, absolutely. Just shout them out.
Traction.
What's the difference between traction and distraction?
Traction is.
Not a whole lot. Don't worry about it. Anything else? Anybody do any P and F?
Yep. Manually resisted
Scar tissue
exercise.
mobilization?
We do isometrics, man.
Isometrics, manual. Okay.
Joint mode.
Joint, just, mobilization, joint mobs, manipulation. So, manual therapy can be all of these things. All right. Now, the funny thing about this is, when you submit charges, and I know you guys did that, a lot of these things are reimbursed at different rates. But there's always going to be a manual therapy charge. So what I would recommend to you is no matter what you're doing through here, because this soft tissue mobilization we could call massage, we could stretching, we could certainly call that therapeutic exercise, right? We could call maybe PNF, neuromuscular re-education, all different types of codes that we can use. Just use your manual therapy charge, okay? Just, it will make your supervisors happy. They're going to get reimbursed. There are certain diagnoses and certain insurances that won't accept neuromuscular re-education. But all of them are going to take manual therapy, all right? But don't forget about the 8-minute rule, okay? You guys know about this,
Yes.
all right? And again, your supervisors are going to be happy. If you're going to do 5 minutes of passive range of motion, let's do 8, okay? All right? And that sounds awful. I mean, it sounds stupid to have to talk about that kind of thing, but it's real, all right? Questions about that? Yes?
So, what if you're at a clinic, well, I'm pretty sure whatever clinic you go to, you're gonna know which things that you don't get reimbursed for, but
You might not know
you
that.
might not know.
I'll tell you this, I'll tell you the reason why you might not know that, because insurance company might change the rules in midstream. They do that all the time. And they're not gonna tell you. They're not gonna call you and say, Robbie, we're no longer reimbursing for massage. But they're never gonna not reimburse for manual therapy. If they start doing that, then we're all gonna be out of work, so.
Yeah. Ran into a situation where, like, putting it under manual therapy, massage and stretching, they were telling me we can't put it together now.
There are some of those, yes, yes. And again, those will change. They'll
It
change
sounds
like
like
the
it
wind.
changed.
It's blowing out of the east today. We're not gonna reimburse for manual, for massage with this, yeah, it's silly. It's just
Tony,
ridiculous.
Rebecca with Jeff, you know the answer is it depends.
It's really true though. Was that another hand? Okay, so we good on this? All right, everybody will like that. Supervisors will love that. CIs love that. Okay, so the term manipulation versus mobilization. All right, so I studied under this guy, Stanley Paris. Stanley's the guru from New Zealand. Founded University of St. Augustine. He's an APTA Hall of Famer, all this kind of stuff. Fabulous guy to go listen to. If you ever get a chance, please go do so. His definition, well, let me say this. He says manipulation and mobilization are synonymous. All right, it's just terminology. His definition for both of these terms was the skilled passive movement to a joint. Now think about how broad that is. That can include all of these things, right? Now he's talking about joints, so we wouldn't say soft tissue work necessarily. But again, very, very broad. Don't back yourself into a corner. If somebody says, well, what are you really doing? We'll say, I'm doing skilled passive motion to a joint, okay? And you covered yourself. Easy. So, Stanley continues to expound, and he loves to expound, let me tell you. Should be directed towards restoring limited accessory motion. Do you remember accessory motion? Okay, so for the example was, if you were limited in external rotation, you want to do an anterior glide to enhance that motion. This is what he's saying. We want to address the limited accessory motion to those within the joint that accompany classical movements. In other words, the anterior glide moving with the external rotation. Okay? And again, all of these, every joint in the body has got different accessory motions. We'll get back to that in just a minute. This could consist of, there's our distraction, non-thrust or thrust movements. We'll talk a little bit more about those. Distraction. Separation of two articular surfaces perpendicular to the plane of the articulation. Okay? So, if we just take our finger and we're looking at an MCP joint that's sitting this way, we want to work perpendicular, so we're going to pull this way, and we can all feel that, right? Okay? So why would we do this? Again, also known as traction force. Different than mechanical traction, which is much more general in nature. Very effective for patient relaxation or pain relief. You guys will remember, if we go way back to shoulder, how I told you I do tons of distraction on shoulders, not to mention cervical spine, hips, spine, all this type of stuff, because it feels good to people. It helps them to relax, all right? Uses, okay? We're going to unweight joint surfaces, relieve pressure on an intra-articular structure. So if we've got somebody who may have a bone spur that is compressing the rotator cuff or a bursa in the hip or something along those lines, many times distraction of long axis traction can be very effective in relieving this. All right? Stretching joint capsules or adhesions. We all know that joints have surrounding joint capsule, soft tissue, connective tissue. We can also have adhesions. Al's got plenty of adhesions through 41 surgeries. He talked about people breaking through some of those things, all right? That happens. And we also do this to assist in the reduction of a dislocation. Obviously, we're not going to be handling that, but that is what they do to do that. Has anybody seen that, by the way? Anybody dislocates an elbow or a shoulder, they will literally put a foot in their axilla and just pull, and it will reduce. Many times you have to knock them out to do that. Non-thrust manipulation. This is what, as PTs, PTAs, on peripheral joints, we do probably, this said, like 90% of the time. Very few times are we doing thrust manipulations. So this is where the joint is either oscillated within the limits of accessory motion or taken to the end of the accessory range and oscillated or stretched. And I've got, where's my little handout? You'll see that in a second. Often relatively low energy, slower velocities of movement, including steady stretch. Oscillations were made popular by Jeffrey Maitland from Australia. We'll touch on that in that schematic as well. Uses, so mechanically we're going to elongate connective tissue, including adhesions. And then this big term, I don't even know if I can say, neurophysiologically, we will be firing cutaneous muscle and joint receptor mechanisms that will inhibit pain and promote relaxation. Okay? Again, we'll touch on all these here in a little bit. Graded oscillations. All right, so let's go back to our long axis traction here. Okay? So if we've got, and you can look on your schematic under the 4 here on the side where it says oscillations, and you see these here. So this is going to be magnitude of movement. Okay, how far you're going into the range, and then this is over time, of course, along the top. So a grade 1 is just going to be just unweighting something and just oscillating back and forth. Small amplitude of movement performed at the beginning of the range. Very light, very, very light. Grade 2, large amplitude of movement performed within the range. You're not getting to the end range, but it's a larger amplitude. And again, oscillation of movement. Grade 3, this is where I spend most of my time, 3 and 4. Large amplitude performed up to the limit of the range, all right? And then 4 is going to be a smaller amplitude where you get to the end range and then you oscillate small amplitude from there, okay? This will describe how you are doing your mobilization peripherally. Has anybody seen this in a chart or had a CI say to you, can you go perform grade 3, any of that kind of thing? Anybody? Okay, good. So this isn't foreign to everybody. If you haven't had it, you will. Thrust manipulations. Not done very often. These are not performed by PTAs in the state of North Carolina. Everything else of the previous slide certainly can be. This is sudden high velocity, short amplitude, delivered at the pathological limit of accessory motion. So if we get somebody, the only time I really do this is on lumbar spine. Yeah. Well, not completely true, but this is the one time I'll do this is lumbar spine. If I've got somebody who's really locked up and I know it's a facet joint problem, I will try to open them up, get them to end range, and then I will give them a quick thrust movement. That's called a thrust manipulation or a grade 5. Okay, so if you see that in a chart, that's what this is. And again, why are we doing this? Again, altering positional relationships, releasing adhesions, and again, it produces a neurophysiological effect to eliminate some dysfunction if someone's stuck. All right? I do not do this at the cervical spine. I don't feel comfortable doing that. I've been doing this 20 years and I don't feel comfortable doing that. There are therapists that do it. I will do something, I will do something with this on a shoulder if I feel like there is scar tissue that's really needs to be broken loose. Matter of fact, I had one of those about a month ago. She did not like me afterward, but it worked. So. Very painful. Okay, so here is that manipulation schematic that we were talking about. This is the top one on your handout. Again, time and magnitude. So you see how a stretch is over a longer period of time. Let's say this is, say, 15 seconds. And we may build up. And we're stretching hamstrings, let's say. We're just bringing it up, holding it, and then releasing it slowly. Okay? A spring impulse or thrust, we'll get to end range, and then we give it that little extra push. All right? Progressive oscillation is just what it says. Oscillations all the way to end range, and then we have grade 1, 2, 3, and 4. And again, you're not going to be tested on this stuff. I just want you guys to be aware of what this is. I thought these, for people like me who need to see something visually instead of just feel it, this can be helpful. The next schematic, it doesn't blow up very well, but you got it on your handout here, I thought really represented what we're talking about in terms of motion. Okay? We have active motion within this realm right here. Okay? And it says loose packed in the middle. You remember our loose packed and our closed packed positions and all that good stuff, right? Loose packed would mean it would be the most allowing of motion, as opposed to closed packed when it's the most congruent and the most stable. So in our loose packed position, we've got our active range here. Joint play, we'll consider for our purposes the same as accessory motion. Okay? So that's that extra bit of motion that we can gain by doing a glide, if you will. Okay? That is what we call our physiological limit. So that's all that you're really going to get out of a joint by you working on it. Okay? Because if you exceed the physiological limit, we're into the strain sprain culprit. We don't want to do harm with manual therapy, so we want to stay within this physiological limit. Okay? If we exceed that, we're going to be doing tissue damage here. Right? But within that, we have an anatomical limitation of motion. If we exceed the anatomical limitation, and it's not something we're going to do onto a patient, but this is the way this works when someone dislocates or tears a muscle. Right? So I figured this might be helpful in black and white. Questions on that at all? Does that make sense? We're getting some deer in the headlines, but y'all just miss me so much. So. Effects. Okay, we've got psychological effects, mechanical effects, and neurophysiological effects. Psychological. Laying of intelligent and skilled hands provides confidence and assurance to the patient that something good will result. How many of you guys did some type of hands-on work that you felt really good about after you completed it? Okay, good. Saw a lot of that. Did you do anything that you felt, man, I just wasn't that good at that. I wasn't experienced at it. I was wishy-washy with it. I just didn't feel comfortable doing it. And that's fine too, because you guys are still learning. What we're trying to do here, especially from the patient's point of view, and that's why I wanted you guys to hear Al, is we want them to have confidence in us. Okay? I think I told you guys a long time ago, when you're doing these hands-on things, be firm, be exact, be precise, be definitive with what you're doing. Because a patient can sense if I'm getting ready to do somebody's mobilization, repositioning and all this kind of stuff. Be confident. Even if it's not perfect, be confident with it. All right? Mechanical. This just goes without saying. This is movement of joints, stretching of tissues to improve mobility. So a mechanical effect. Easy. This is where it gets incredibly gray. Neurophysiological. Right? We've got all these types of different sensory receptors, mechanoreceptors, all this stuff within our body in joints, soft tissue, cutaneous, all these areas, which provide pain relief and reduction of muscle guarding and holding. I don't even want to pretend to tell you that we understand all this stuff, but we know when we place our hands on a patient, they have done studies after studies after study that we know there's a psychological component. There's certainly a mechanical component. But there is something that we cannot really put a finger on that happens. Why? Why does it happen? How does it happen? We don't know all the answers to that. We've got theory, but it's vague. So this psychological effects, really important to understand that this is a component of manual therapy. It can't be the basis for your manual therapy, but you've got to consider this, okay? How many people dealt with somebody that you knew right away did not want your hands on them, okay? And that's sometimes hard to get a grasp of, all right? But there are certain people that are just hands-off people. What do? Do you alter your treatment plan? Absolutely. Absolutely. You may just say, okay, we're not going to do any hands-on work. We're going to, instead of me stretching your shoulder, I'm going to put you on a pulley and let you stretch your own shoulder. That kind of thing. Okay, so you've got to consider this type of thing. The psychological effects, again, and this starts from the evaluation process as well. When I'm doing, especially an initial evaluation, I want to make sure that I do have my hands on this person at least some. I need to palpate structures. I need to feel for infeels. I need to feel if there's some type of swelling or if there's muscle guarding, what have you. But I want to make sure that I've got my hands on them because they need to understand that this is a hands-on profession. Okay? That sets the stage for stuff that you might be doing with them afterward. And if you've got a PT that doesn't do any hands-on during the evaluation, that's going to make it hard on you when you come in to do that. So you need to, you don't have to sit in on a patient eval, but I think it's important that you at least know what your PT is doing. Okay? You can ask them. How many people have done some type of hands-on work and gotten the pop? Okay? So what did you feel about that? Did you feel that was a good thing, a bad thing? What? Horrible? No good.
I had a shoulder that opened it off. I was just, passive brain.
Yep.
And it just popped, and I was like, he didn't react.
He didn't react at all.
He said it hurt, but I mean, he was able to move it.
Well, it's
and-
probably because it happens all the time to this guy.
but at the same time, then when I went to move it again,
Yeah.
passively, it hurt.
Okay. So something was disrupted there. Could that have been scar tissue? Maybe. Could it just been some incongruency in the joint and things popped and subluxed for a moment? Could have been that. There's all kinds of things that this
It was
could
like
be.
the first time I had done passive range on a patient too. So.
And boom, you get the pop on the first one. Anybody else had that experience? Yeah, just share.
I just told him up front that I was gonna stretch him out, see what we found in the joint. And so when it popped, I asked him, well, how did it feel? And I let to see what kind of movement we got. And I just pointed out the positive from it.
That they got more motion out of that.
Mhm.
Okay, good. Anybody else?
Exactly.
Similar?
More than once, but after each occasion, I was like cringed a little bit, but they were like, "Well, it hurt, but it feels better."
Now it feels better. Okay, well, good. And that's when you have to spin it a little bit and say, okay, you felt that, but look, now you got better motion. You got, yeah, that's a good thing. And we'll talk a little bit more about this, the neurophysiological effects of the pop in just a minute. The laying of hands. Okay, so we talked about this earlier. It needs to be caring. It needs to be intelligent touch. Does that make sense to everybody? Having a purpose for touching the patient, not just going over there and just willy-nilly, okay? It should be soothing. It should be professional at all times. Confident. Good grip. Yet supportive. You don't want, we've talked about this before. We're doing some type of mobilization. You got half their body hanging off the table, and you get ready to do something, and they're getting ready to fall off. You can't have that. You gotta have support there for them. They will be relaxed if you do that. Encouraging relaxation, and while we oftentimes do cause discomfort or cause pain, that's not going to be the primary goal of what we're doing. Our primary goal may be we need to increase motion, and we may need to break through some adhesion or what have you, but we're not there to cause pain, obviously. Give the patient value. All right, what I mean by this is they are coming to see you as a healthcare professional. They are forking over. How many co-pays you think Al's paid in his life?
Oh my God.
You believe? Think about that. It's amazing. They're coming and spending hard-earned money to come see you, okay? What are you giving them that they can't get somewhere else, right? Can they watch a YouTube video and learn exercises?
Mhm.
Absolutely. Now, don't misread this. I'm not saying that that's as good as what we can give them. But from a patient's perspective, you've got to give them value. You've got to give them something that they can't get on their own or through a family member or through a pill or through another healthcare provider, right? And we got a lot of competition out there. So give them value. And our value, I believe, many, many times is in our hands. Our hands-on work separates us from other professions in healthcare, okay? Nursing really doesn't do much hands-on care. Doctors don't do much hands-on healthcare, unless you're dealing with surgeons, that's a little bit different. Massage therapists, that's all they do is hands-on care, okay? They don't have the exercise component. We've got a unique niche, but don't forget about the hands-on part. It's vital, okay? Give them value. And again, that last statement, the physiological effects are not the justification. You are not doing manual therapy to make someone feel better. Well, it might be soft tissue and massage, maybe. But again, it's got to be a physiological mechanism there. You've got to have somebody who's got tight muscles. You're not just in there, it's not the spa. Okay? But it's still got to be a consideration. You have to think about what is the result of your hands-on work. Does that make sense? Okay. Mechanical effects, these are easy. We're stretching out tight capsules, we're breaking through adhesions, we're altering positional relationships. We might do a patellar glide that's just going to allow for more motion to occur so we've got better flexion and extension. Okay, we may do a traction force like we were talking about earlier that will unweight two joint surfaces where we've got some inflammation there, we've got some impingement going on. This is really easy to understand and to see. All kind of, we listed a bunch of them down here. And I listed some abbreviations. Does anybody see LLPS in the chart? Low load prolonged stretch, yes. An accessory mobilization you will see as written as glides, joint play. That's probably the two that you'll see most often. All right, mechanical effects. When we have the stress and strain curve, have you guys, I can't remember if you guys had this in Kines. If you did, I apologize. Stress and strain curve.
What's sound familiar?
Stress, strain. I know you missed my writing. All right, so there's this. Anybody remember something like this?
Not at all.
Okay, good, good. You're learning something today. Okay, this is what we call the elastic phase. Would everybody agree that if we pick up our skin, now I'm old, so mine doesn't go back as quite as quickly as y'all's. Everybody pick up the skin on the back of your hand or wherever. All right, hold it for about 5 seconds and then release it. Okay? Does it eventually go back to where it was? Yeah. That's your elastic phase. Meaning we are obviously deforming tissue, obviously doing something to it, but it's not making a permanent mark to the point that it's going to stay that way. It's going to come back. Now, mine takes about an hour to get back. This is what we call our plastic phase. This is not a great example here. Let's go to our shoulder. If we're doing, like we said, that anterior glide to try to improve external rotation. If I glide it grade 1 and just easy, 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 that's going to be in our elastic phase where we're not making a deformable difference. Maybe it helps them with pain relief. But when I get up into grades 3 and 4 and I'm at end range and then I will oscillate, okay, I'm trying to make a difference. I'm trying to make a plastic change. I increase stress, so strain is going to occur, okay? So I'm trying to make a change at that joint surface, at the connective tissue around it, at the ligaments. I'm trying to gain motion here, okay? Now, if I do too much, then I reach what is called ultimate stress, okay? At the end of this plastic phase is ultimate stress. At the end of this stress and strain curve, at this point, tissue is failing. We are getting separation that cannot be reversed, okay? You are getting tearing of fibers, whether that is connective tissue, muscle tissue, what have you. You cannot come back from this, okay? And that's why not many of us will do grade 5 mobilizations, because on a high velocity, low amplitude, we don't know where this is. We don't know how much is too much when we're doing high velocity stuff. Slower velocity, we can work up to that. And you can get a feel for these things. And this is a feel stuff, okay? I can't tell you that, hey, if you pull with 40 pounds of pressure, number one, who knows what 40 pounds of pressure is, okay? But I can't tell you how far to pull that's effective. That's why you have to communicate with that patient. Okay, luckily these people aren't asleep when we're working on them. Well, hopefully not asleep. They're dead. All right, so the effects. What does heat do to that stress and strain curve?
Can
It increases it.
make it longer.
Increase the lactation.
It's going to make it longer. That's right.
Somebody
We had-
better answer that.
Huh?
Somebody had better answer.
They said they'd never seen this before. Stress strain. Uh-oh, she's boiling.
We didn't say we never saw it. We said we don't
You don't
remember,
remember it.
Yes.
That's even worse.
it. It's the truth.
Modalities.
The effects of heat.
He asked if we said Canese specifically. He said
All right,
specifically.
sidebar later. We're on the time schedule. Heat will stretch this out. Okay, we're not gonna have the brittleness. We're not gonna have the it will be easier to reach the plastic phase, but harder to reach this ultimate stress. Does that make sense?
So that just really widens plasticity.
Yeah, exactly. Exactly. So we're not going to have the brittleness of tissue. All right, so methods of heat. Give me some methods of heat.
Moist hot pack, ultrasound.
Moist hot pack, let's talk about that. Is a moist hot pack going to affect the tissue that we are trying to mobilize?
Like, no, every-
Possibly.
Possibly. It depends.
On the
Yeah,
joint.
it depends on
Explain.
how deep the tissue is.
Depends on
It
the
depends on
joint
what
size.
tissue you're trying to mobilize.
All right? If I want to mobilize someone's shoulder, I put a hot pack on their shoulder. Is
Depends
that
on
going
the
to
legs,
get
too.
to the glenohumeral joint?
Depends on your layers too, how much layers you put.
You take the hottest hot pack in the world, and it is not going to get deep enough to affect the glenohumeral joint. Now, stay right there for a second. Are there effects from that heat?
Yes.
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 What are the effects from that heat?
Relaxing.
Relaxing. Is that important?
Yes.
Yes.
Blood flow.
Blood flow. Is that important?
Yes.
Yes. So it's not that we don't need to do moist hot packs, okay? Pain. They just may relax better and have less pain to
Just
allow
guarding.
for an easier mobilization, okay? So there can be positive effects with a moist heat pack, but do not, and that's a board question I'm telling you right now, do not expect that to affect the mechanics. It's not a mechanical change at the joint, okay? Ultrasound. Tell me about ultrasound. Can that get to the glenohumeral joint?
Yes.
Okay.
I feel like it just depends on really what you're looking to do.
I would agree 100%.
Right, if you're looking to heat up specifically those deep tissues, then yes. But if just pain,
There's very little research that's going to say that pain is affected by therapeutic ultrasound.
right,
Very little.
right,
Very little. You could maybe find 1 or 2 studies out there, but you could probably find 20 that will say it doesn't. So I would say I would lean on the side of it doesn't.
right.
But yes, can you affect the joint? Yes. Yes. Do I do it all the time? No. Why don't I do it all the time? Time considerations. I feel like the 8 minutes I might spend doing ultrasound, I can get more out of a patient in 8 minutes with my hands on them. I might feel that 8 minutes of exercise does a better job of warming tissue than ultrasound does. Plus, they get something else out of that too. They're getting cardiovascular health, they're getting whatever. But I have one patient right now, a frozen shoulder patient, that I put in a low load prolonged stretch, external rotation, and I heat him for 8 minutes with ultrasound right here. And I feel good about it because even if the ultrasound is a complete sham and I'm getting nothing out of that, I'm still getting 8 minutes of stretch in this position for him. Okay, so I combine the modalities, if you will. Anything else, methods of heat? Just mention one.
I mean, that's probably,
Exercise.
Exercise might be our best one because it's systemic. All right? I would much rather put somebody on the UBE for 10 minutes than do 10 minutes of ultrasound. Because think of all the other stuff that they're getting. Okay? Blood flow, we already talked about that. Range of motion, you're getting some resistance. They're getting systemic effect from it as well. So, again, weigh your options. Any other methods of heat? Did anybody see a diathermy unit while you were out there? One diathermy unit? Did you ever use it? Did you really? I've been 20 years of practice. I have seen it, but I've never used it.
We used it in 2 different things.
The French fry heater you have used. That's awesome.
Because you can charge for it.
You can charge for it. Did you feel like it was effective?
With one lady, it was hard to tell. The other lady, I don't think so.
Did you explain the entire modality to them? Did they ask you?
No.
Now, here's French fry light. Flip it on. Go.
Yeah.
Yeah.
But my CI did some, it was not because of some way they had it set up.
It was what?
Not.
Good. All right, so now we get in the gray area. How we doing on time? Because we have a meeting at 12:30 that we have to get to. Okay, we're good. Neurophysiological effects, again, all this stuff that no one understands. You can talk to muscle physiologists and they'll give you all this stuff. Did anybody have to explain gait control theory to a patient, or did your CI explain it?
I did the one.
Did you feel like you were effective in your explanation?
Yeah, because I gave a really, really dumbed down version of it. So yeah,
Hit
they
us
understood
with
it.
Hit us with it.
I gave them the, basically one cancels out the other.
Okay.
That your body's only going to pay attention to one thing at a time.
I use that one all the time. I think that's as simple as it gets, and most patients kind of get that. You're flooding the pain circuit, if you will, with the perception of the stimulation, as opposed to the perception of pain.
The example I used for the most part, because it was a mother, I said, if you're doing something like your husband's getting on your nerves, but your kids keep going, mom, 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 kids allow you to tune out your husband.
Yep. Yep. And it's not just tens. It's like Chris was saying, something distracting in the background, noise, rubbing skin. You'll see people all the time that have some type of chronic pain or whatever. A lot of times they're rubbing something like this, or they're tapping it, or they're doing something just to take their brain off of that. All right. Vibrations, oscillations, all that kind of stuff can be effective for that. Again, consult your local muscle physiologist if you have questions. The pop. So when a joint pops, what is actually happening? Physiologically, what's happening?
Release of nitrogen.
Nitrogen gas is released. Okay, so what does happen after that?
I read it.
Okay, so if the gas is released,
There's more space.
fluid can go into there. Okay, so it provides a little bit of swelling at that joint surface. All right, so that little bit of swelling acts as a distraction. So that's why it feels better to these people when they do this. Okay, there is a physiological, it's not just the mental stuff of the pop. Joint surfaces will separate a little bit. Now, with that separation, we've got these type 3 mechanoreceptors fired by swelling. The muscle tissues then relax around it. Okay, and again, those are neural inhibitions there, right? Endorphins can be released. So again, for the most part, this feels good to them. Well, what's the negative of popping your knuckles or getting this pop or popping your back or your neck all the time? Well, the muscles are relaxed. So would you agree that there's less stability there? More potential for subluxation, what have you. All right? And then at the spinal level, potential trauma for disc and instability can occur. Your desire to pop again, they become dependent upon this. Okay? I've seen this happen. How many people you've seen to just pop knuckles constantly or pop their back all the time
Me.
and all that stuff?
I do it all the time.
Yeah.
I do it.
Yes. Do we have a question in the back?
No, I was raising my hand because I knew.
You know people that do it, yeah. Discourage it. So our goals, we talked about this earlier, pain reduction, improving mobility, reducing muscle guarding, improving function and performance. Here's one that, as vague as it gets, but assisting in nutrition and repair joint structures. We can influence fluid exchange with what we do. Improving alignment, breaking down scar tissue, that's pretty obvious. Precautions and contraindications. My man Stanley said there are no absolute contraindications but many precautions. I don't know that I agree with that. I'm certainly not going to mobilize a hemoarthritic joint with blood in it. I love this statement. When in doubt, don't. If you have a question whether you need to mobilize a joint, you probably don't need to do it. There are many, many people with hypermobile joints that would love to have their back popped or their shoulder stretched out, where you're actually doing them more harm than good, even though it might feel good to them. Because you're just setting them up for that level of instability is going to get greater and greater and greater. You should be working on strengthening with these people. Adverse reactions, things we don't want to see. Obviously, sometimes you will get increased pain from manual therapy. We hope that's not the case. We don't want to see more guarding. We certainly don't want to see swelling. We don't want a decrease in motion, but that usually will come with one of these, okay? And we certainly don't want a decrease in function or performance. If you see these things, then I think you need to, number one, look in the mirror and say, okay, did I do the right thing? And two, am I going to do this the next time? So these are things to discuss amongst yourself, but also with your supervising therapist and the patient as well. Let them be a member in the decision-making process, whether you're putting their hands on them or not. Hey, how did that feel? How did you feel 2 hours later? What did you feel like the next day? A lot of these people I don't see but once a week, and I got to go back 6 days to say, how did it feel after we got done? Okay? It's important. Okay, so our governing body of physical therapy in the state of North Carolina has answered the question, can a PTA perform peripheral and or spinal mobilization in North Carolina? It's a confusing question, but even more confusing answer. A PTA is authorized to perform patient-related activities which are commensurate with the PTA's education and training. Have you been trained to do peripheral mobilizations?
Yes.
Yes. Are you proficient in them?
Yes.
We're getting there.
It depends. Define proficiency is what you should say. Okay? The board has determined that in 2010 that it is inappropriate for PTAs to engage in spinal mobilization under any circumstances. All right? Again, they're going to contradict themselves in the next slide. Peripheral mobilizations have been done forever. It's less clear, certainly not a mobilization, but it says on here, typical PTA education does not provide sufficient education and training for a PTA graduate to perform peripheral mobilization. Obviously, we are not typical, because I feel like you guys, in many ways, in many joints, proficient to do this. Okay? But that's their statement. That's coming straight from the board. Updated in 2015, it said before, spinal mobilization completely prohibited. Now, gentle manual cervical traction is not considered mobilization and is not prohibited. Define gentle. Oh gosh, we gotta go. Define gentle. SI, no-go. Competency is determined by the supervising PT. Sorry to rush. We good?
Evaluations on the back table.